Hello, thank you for joining us today and welcome to our webinar, Building Up Your Restorative Program. I'm your presenter today, and my name is Wendy Underwood. I have a passion for restorative nursing programs, and in my 19-year career, I have worked to build new restorative programs, in-service ones that want to be revamped, and continue that ongoing training for restorative. I see the value in a restorative program that has a nursing and therapy collaborative component. So I want to share that with you today. So let's get started. Where do we get our information? Well, the same place you do, the Resident Assessment Instrument, the RAI manual. And the definition for restorative in the RAI manual, it tells us restorative are nursing interventions that promote the resident's ability to adapt and adjust to living as independently and safely as possible. When I'm interviewing staff or starting a program with an administrator or nursing staff, I let them know this is the difference between standard nursing care and restorative. When restorative goes in, they are trying to get the resident to do as much as they can on their own before they swoop in with that program. When you're a CNA and you're going in to get everybody ready for the day, you're going to do a little more for them than the restorative aide is going to do. So that's the difference. Programs must focus on achieving and maintaining optimal physical, mental, and psychosocial functioning. And right now during COVID, many of you are on this webinar because you see a decline in their physical, mental, and psychosocial functioning. And restorative is an amazing way to plug in and help those residents. And a program is defined as a specific approach that's planned, documented, monitored, and evaluated. And what better collaborators for this and partners with the therapy program? We are designed to have specific approach that's planned, documented, monitored, and evaluated. So use your resources. And we get all of our instructions from the REI manual so that we can make sure that you're in compliance with your restorative program. But you have to start by building a firm structure. Your restorative program must be in compliance. It has to be one of the qualifying programs for Medicare. You want to make sure that you're utilizing restorative to their best ability with those qualifying programs, and we're going to go over those. Skilled patients must get 2 of those qualifying programs, and it's the same as with our long-term residents. Programs must be at least 15 minutes each, so you can see where each resident would have 30 minutes with restorative each day, 6 out of 7 days. Will be carried out by a trained staff member. You want to make sure that they're competent to implement the programs, do them correctly so that you can get the best outcomes. And restorative can see 4 people in a group and they can be doing different things, so we can make sure that their time is very efficient. And what are the qualifying programs? Well, it's very specific on which ones qualify. Walking and or bed mobility, splinting or bracing. Now, it could be walking and bed mobility or both on the plan of care, but you'd want to make sure you have that third program because walking and bed mobility is going to count as one. Splinting or bracing, it could be an upper body splint and a lower body splint, still going to count as one program. Range of motion, it could be upper body, lower body, active, passive, whatever the resident needs, but it's going to count as one program. And transfer training could be the exercises leading up to a transfer or the actual transfer, and that's going to qualify as a program. Communication training is my favorite. This is where all of our awesome cognitive approaches can go in, our brain games, keeping the resident at their can-do level. Those programs are really engaging for the residents. Dressing and or grooming, eating and or swallowing, those are going to count as one program. Amputation and prosthesis care, this one is underutilized. I don't see it a lot, but it is a qualifying program and they see the value in providing this for skin integrity issues, for wounds, just making sure that we're doing the best care we can for someone with an amputation. And toileting, whether it's bowel or bladder, that's going to count as one program. And there are reimbursement possibilities or opportunities under PDPM for restorative. When we had restorative in under PPS, we could have that rehab low category, and it was kind of a transition from therapy to nursing. Under PDPM, we see where nursing, restorative programs, and therapy can be in at the same time and really working towards the same goal of the best outcomes. So if the resident falls under PDPM in the bottom two categories, so those nursing components, then there is a minimal daily rate increase. But the impact is indirect in most cases with under PDPM. You can see so many different ways to improve your reimbursement and decrease your cost by having restorative in. We're going to talk about that next. So many ways that we have so much cost related, we can implement restorative and really decrease so many of those areas on our CASPER report. So we have our CASPER report and we see where our falls, we're above the national average, and that's really costing us a lot. It's costing us admissions. They're going back to the hospital. We can see where restorative could impact that with a good walking program, with exercise, range of motion programs. Weight loss, ADL help, skin integrity, pain, UTI, mobility. Honestly, I can see where restorative plugging into every CASPER measure could improve them. Our caseload impact, if you're a CMI state, you know that having more people on restorative does help your daily rate. But under PDPM, it can impact your caseload as well. Decreased risk of rehospitalization, that's very costly. And you can't put a price on customer satisfaction. When a resident comes in and let's say it's during this pandemic and they're going to be isolated to their room, well, they've got all these therapists coming in. They've got their nursing interventions. They have restorative coming in to do their program. Then there's an activity later that maybe, they do have to do in the room, but they feel like they are engaged all day, even though you're under this pandemic. Staff efficiency. If you have an efficient restorative staff, you can pull them for all those amazing other things you want them to do because they have completed those restorative nursing programs. Maybe they did utilize the group, and we can use their time most efficiently. And your 5-star rating, and that's how we measure success for every facility. But in order to impact all the quality measures, we need to identify who will benefit from restorative nursing. And we have to communicate those changes, all changes. If a resident has a decline, we need some type of hey therapy, or maybe we talk about it at the morning meeting, or some way to say, hey, we see a change. But maybe the change is for the better. They're walking better. They were they had a medication and they were kind of in a fog, and now that medication is gone and we see them doing so much better. So we want to plug in restorative to make sure they're at their best. So we want to communicate all changes, whether it's through a hey therapy form, morning meetings, weekly review meetings, care plan meetings. Especially now, during this pandemic, you are all under review. Everything you do for your resident and all your care, everyone's looking at how are you going to get them better? How are you going to get them through this pandemic? And you're at risk for certain tags related to, let's say, activities of daily living, F676, F688, increase or prevent decrease in range of motion, mobility. Well, we know with whether they have COVID, they're recovering from COVID, or they are just declining due to the isolation, we are at risk for a decline in their mobility and range of motion. So we want to protect ourselves from tag F688. F690, bowel bladder incontinence. F693, tube feeding, restoring the eating skills. We want to make sure that we protect ourselves from all of these risks, especially now. And I think a lot of you are on this call today because you know you need to plug in. You know you need restorative to help get you the best outcomes for your residents during this time as they're recovering and upon working on their skills for all the decline they have from the isolation. So let's get started. What do you need to do? We've heard why we should have restorative nursing in right now. You see how I am adamant about the value of restorative, but why right now and how can we do that? Well, you have to be set up for success. Are you adequately staffed? We do a needs assessment with our customers and make sure that we're set up to provide the best for your individual facility. Do you have a designated nurse that can take on the restorative duties? You're going to use therapy to your advantage. You're going to have them plugging in everywhere. But at the end of the day, it's a nursing program, and you want a designated nurse working with that therapy team. Is your MDS staff trained to code restorative? You want credit for all the great stuff you're doing for your residents. Does your therapy team have a plan to assist you in successful implementation? And what qualifying programs do you offer now? And what do you want to add? Building the restorative program takes a team. It takes a village, like they say. And you're not alone. You need to use your experts and your therapy team. They are the experts in implementing and recommending those programs for your restorative nursing program. Your restorative nurse is going to approve those programs, but the organized method in which we do therapy works right into where we do restorative. Therapists are available to recommend those programs, review them with you and your nurse. They provide the ongoing training and competency for your restorative aides so that you can ensure that they are ready to provide those programs. We can help with hiring the restorative staff with you, interviewing, getting you the right people for the right job, or maybe your therapy team hires the restorative aides to work under your nurse. We help with documentation audits and help you stay in compliance. We're used to that. We're used to having to be in compliance for everything we do as far as our interventions. We can help you be in compliance as well. And why now? Well, COVID-19 hit, and it is impacting those with COVID. Our declines are happening with those with COVID, those recovering, and like I keep saying, those people that are declining due to the isolation and the physical distancing are seeing a decline too. But with COVID-19, let's take at our picture the lungs, for instance. Well, if you have decreased breath support, you're going to have decreased ability to communicate. You're not going to be able to move as well. You're not going to be able to walk as far, get to the bathroom. You might see incontinence due to not being able to get where you need to go because of your breath support. We can plug in restorative in so many ways for somebody impacted like that. Maybe it's the brain and they're having a cognitive issue due to the decline and they're dealing with COVID or coming out of the COVID and recovering. We see that it's impacting problem solving and safety. Well, we can plug in restorative there too. So COVID-19 hit, but restorative shouldn't be something you put to the side, and maybe you did. Or maybe you want to start one from scratch because of COVID, and that's why you're here today. But we have so many ways to help those residents. For instance, let's take all of these programs here, the transfer training. Well, who could impact from that? Well, those recovering, those with COVID, and those with decline due to the isolation. There isn't a program, a qualifying program where I can say, no, that wouldn't qualify. All of these programs do. They are going to be the lifeline for these residents dealing with this pandemic. And then let's say you're out of the woods. You're into the COVID-19 recovery stage, or you're in the preventing decline stage, because you know this could all happen in the future and you want your residents at their best. If we can get residents better now with their respiratory strength, with their endurance, with their physical strength and well-being, if we can get them to a point now when we do have another pandemic, hopefully we don't, but if we did, our residents aren't going to decline so far back because we have them so far forward in their recovery. So we need to think of ways to do that. And in order to do that, you need some preventative and recovery type systems in place. So maybe you have breath support groups and they meet or maybe it's you still have to do them in room, and that's okay. It can be virtual. A Better Breathers Club from the American Lung Association is so easy to start at your facility. You can become a host site. So let's say you are in the preventing decline stage, you're able to have people come on campus again. What a great marketing tool that you're known for pulmonary health. You're known as the respiratory rescuers, and the American Lung Association has provided that tool for you. Range of motion programs, wellness programs, whether it's in room because of isolation or whether it's out in a group again. Having a wellness class for everyone to go to will impact how you deal with a pandemic in the future. Respiratory muscle training programs can work wonders for getting everybody to their best pulmonary health before another decline happens. And mobility programs, a walk to dine. If you don't have some of these things going and you're able to do this and get the residents out and about, we want to provide that for you. And therapy is going to be your experts in getting all of this done. And you want some preventative facility-wide programs. You want everybody engaged. I love the Move on the Twos program. The goal is to promote pulmonary health and function and circulation and skin integrity, and it's so easy to do. We tried to make something where it's realistic and everybody in the facility can do it. So every 2 hours, maybe you play a song over the PA system, or just everybody knows on the twos, we're going to go do this. But wherever I am in the facility, I'm going to stop what I'm doing when it's that time, and I'm going to encourage and assist in resident movement. So if I'm in the room doing ADLs, we're going to move and groove, do the YMCA. Maybe I'm helping the roommate too, and we're both engaged. I'm going to turn any residents that need to be turned at that time if I am in the room, or change their position. If I'm in the gym with them or I'm in the activity room with them, I'm going to maybe get them up and get them in a different chair out of the wheelchair, or maybe put them in a recliner. I'm going to change their position every 2 hours. I'm going to have each resident I'm with take 2 deep breaths. And then I'm going to assist them in hydrating. I'm going to check and see how much they've had that morning. I'm going to make sure I encourage the hydration. And I'm doing this every 2 hours, no matter where I'm in the building. We're going to stop what we're doing. Hopefully there's a cool song playing, and we're all moving and grooving and working towards our preventative declines, preventing those declines. We do have this handout available for you. If you want to start a Move on the Twos program, it's very easy to follow. All staff can participate, and you can make this something that's really realistic for your residents to help prevent decline. But maybe you're not in that preventative stage and you're actively engaged in a COVID-19 outbreak. You have to still keep everybody moving. You can use your PA system for stretching exercises, breathing exercises. You can have exercise cards that stay in the room so that you're following any sanitary precautions. You could do a name that tune activity with where you're maybe the activity staff are doing some different things. You can make sure that you still give them that hydration, and you're encouraging more hydration. If they're in bed, which many facilities have told me they are just trying to protect those with COVID or those recovering from COVID, and they just want to keep them comfortable in the bed. Well, in bed puts them at a higher risk for pneumonia, weight loss, mobility issues, skin issues, blood clots, all those things that would just decrease their chances of getting over this COVID-19. So we want to get them up, get them engaged, even if they have to stay in their room. And you can overcome the restorative nursing barriers. There are some. Staffing's the biggest one that I'm told all the time, and I understand, I've been there. But maybe your therapy team hires the restorative staff. They take on that burden for you. That would be great. And then they work with your restorative nurse, but they're taking on those staffing issues. Maybe the barrier is the efficient scheduling, and maybe you need the therapy team to help you with scheduling restorative aids. We know how to be efficient with our time, and we know how to group people, so we can help the restorative aid use their time wisely. And a lot of times, restorative aids are pulled for other jobs in the facility. They're helping with weights, they're helping with meal prep, they're going on physician follow-up visits. Well, what if we could incorporate one of the programs into that? Let's say it is they're doing the weights for your facility, and they're going to do the weights for all the people with a walking program or a transfer program, and they're able to check off the restorative program and get that weight for you. That's an efficient use of their time. Another barrier is documentation and compliance. Well, what if therapy did hire that aide? They're in charge of that participation grid that's required for the resident each day that they see them, and they've taken on that compliance for you. Maybe therapy assists the nurse with their monthly summaries. The rule on the REI manual is periodic documentation from the restorative nurse. So we like to say monthly, but maybe we're providing weekly summaries so that that nurse has an easy job when it comes time to do that monthly note. They know what the resident's been doing all week, each week. And maybe therapy completes the restorative nursing compliance audits, documentation audits, and you have something to show that you're in compliance with your documentation. So that barrier, if you plug therapy in, you can have a wonderful solution. All right, we hope you've enjoyed today. We have a few takeaways for you. We want to let you know that restorative is a nursing program and it's supervised by a designated restorative nurse, but therapy can be a major leader in assisting that nurse with your program implementation, with your efficiency, documentation, and compliance. We can truly help you get over all those barriers, and you can provide the best care, even during a pandemic, using restorative nursing. Restorative nursing is vital to decrease decline from COVID-19 and the decline due to social isolation or physical distancing. And there are barriers, but we can work through them together and overcome them and really use this time to make sure that we are prepared for future pandemics as well. Here are some of our references. I like to dig deeper when I'm at a webinar, so if you want to dig deeper, here are some of the tools that we use to get the information for today. Many times we're asked, how does restorative grouping work? How does it look? Well, right now during a pandemic, it may look a lot different than when we're out and about and the residents are in the dining room and go into activities. So right now, if two residents are both on a restorative program, it just may be a roommate group, a group of two. They can be doing different things. Restorative can have up to 4 people every 15 minutes, but in a pandemic, they may be able to just group 2 or maybe 3 residents get to come to their doorway and the restorative aides in the hallway leading some range of motion. So grouping is going to look a little different right now. In wonderful times, a great group would be a restorative dining group, where restorative may have 8 residents at their table. They're providing all the program implementation, and within an hour, they have knocked out 8 programs. So that's a great use of their time. Doing the wellness classes when restorative and activities work together and lead those wellness classes when we are able to have everybody back out and about, that's a great way to do a lot of the programs. And they could be different. It could be several residents are doing range of motion, some are doing wheelchair push-ups, and that leads towards the transfer training programs. And maybe some are doing some pelvic floor exercises, and that would be towards a toileting program. But everybody's in there and engaged. So hopefully we can get back to grouping, but right now it will look different. Another question we have here, toileting programs. We do understand that restorative's not taking everybody to the bathroom all day, but there are some ways where it would be appropriate to have restorative doing a toileting program. Maybe it's a prompted voiding, where Mr. So-and-so just doesn't want to use the bathroom during the day. He's just so busy, but restorative is trained to go in with a certain intervention and they say, it's time to freshen up, Mr. So-and-so, before lunch. And that tends to work for him for a couple weeks. And then restorative can train the nursing staff, and maybe that's, you know, the verbiage that works for him, and that's what they do. Scheduled toileting for some people could look like a scheduled time that therapy's worked out when they've had them on for urinary incontinence. They take them to the bathroom and the restorative aids in there. And maybe for that resident, the intervention is they do their business, but then they have to stand up, take a couple deep breaths, reset that autonomic nervous system, they sit back down and they're able to void again. And that's somebody that would have had incontinence or would have had to go right back to the bathroom. So that would be an appropriate restorative intervention because that's what works for that resident to remain continent. And then again, the pelvic floor exercise program, that is part of toileting training. So to remain continent, they need those pelvic floor exercises. So that would be another use of the toileting training for restorative. And if you do come up with any other questions, definitely email us, let us know. We love to hear from you, and we're happy to answer those. Thank you so much for joining us today, and we hope we have provided you with some helpful information and some realistic implementation ideas for your restorative nursing program. And our monthly educational webinars will continue next month, and we look forward to hearing from each of you. In the meantime, our thoughts and prayers are with you as we continue to face the challenges of COVID-19. Thank you again, stay safe and stay healthy.